And as you'll see, I'll suggest that those right or appropriate signals are intracardiac or pulmonary artery pressures and lung fluid content. That really is at the heart, no pun intended, of the heart failure clinical syndrome. Secondly, the sensors must be accurate. They must provide absolute values, not relative ones, and that was a hard lesson learned with about a decade's worth of research on transthoracic and intrathoracic impedance technologies. Knowing when the lung's wetter or drier, but never knowing if it's normally dry or when it's wet, how wet it is of very limited utility. And because of that, those technologies turned out not to be actionable, so that's the fourth A. The information must be directly actionable. If we know what the pulmonary pressure, the left atrial pressure is, we know what to do with it. If we have an absolute measurement of lung fluid content, we know what to do with it. And all of these surrogate measures and relative measures really leave us more confused and don't really tell us what to do. And then finally, we need treatment algorithms, because even if you meet all of the four prior prerequisites, if you don't use the information, you're not going to improve clinical outcomes. So we need to know how to use the information. I've slightly adapted this description of the time course of heart failure decompensation leading to heart failure hospitalization that was published a few years ago. And to make a long story short, I think most of you are very familiar with this scheme, that in addition to filling pressure increases, which are at the far left of this figure, the earliest changes that occur on the road to heart failure decompensation, detectable absolute changes in lung fluid volume are also reliable measures of heart failure decompensation that occur early and earlier than all of those other physiological predictors of worsening heart failure, such as changes in heart rate variability or relative changes in intrathoracic impedance. And of course, at the end of the road, just a day or two before patients get admitted, they become acutely symptomatic and perhaps have a detectable change in weight. Well, first of all, what are the prerequisites for a heart failure management tool? Remember the 5 A's. Should we treat fluid or pressure or maybe both? I think both are important, and we can talk a little bit about the complementary roles of REDS and an implantable hemodynamic monitor, such as the CardioMEMS HF system, in managing our patients. How can we care for and manage our patients throughout the hospital to home continuum? Well, by using REDS, point of care, and in some patients, an implantable hemodynamic monitor when home monitoring is required. Are CardioMEMS and REDS competing or synergistic? I believe that they're synergistic or complementary. And how and where should we use lung fluid assessment as a heart failure vital sign? Well, I think after you hear the remaining presentations this evening, you'll see that it is quite useful in a variety of settings, including the emergency department, the hospital, the early post-discharge period in the clinic, the office, skilled nursing facilities, and as part of VNS programs.